Meeting the ever-changing healthcare needs of our communities, Paris Community Hospital Family Medical Center is now Horizon Health, with the same ownership, management, providers, and employees. Horizon Health provides patient care and promotes wellness to the communities of East Central Illinois.
At HS St. Anthony's Memorial Hospital, we are at work transforming heart care, rebuilding knees and hips, delivering new generations, and focused on providing health care to you. We are HS St. Anthony's Memorial Hospital.
Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System.
At Carl, we dedicate ourselves to helping you be great. And we have the expertise and inspiration to help you stay that way.
Hi, and welcome to this special live edition of Being Well. I'm Keanne Armstrong, your host for this evening's program. And tonight we are going to be discussing a very important topic that is actually crippling our nation and locally. It's the opioid crisis, something that is affecting many people, and they may be your family, they may be your neighbor, and it may be your coworker. And tonight we're going to be learning all about opioids and how to get help for the people who need it most. And we're going to be having a live panel of guests here with us. We have special guests in the studio. I'm going to introduce each of you. This is Judy Brown, and she is a program director with Seed Council. This is Michelle Eaton, and she's also with Seed Council, and that's located here in Charleston locally. It's Central East Alcoholism and Drug Council. You're with Prevention. Mm-hmm. And I also have Joe Trotter, and he is a prevention specialist at Champaign-Urbana Public Health District. And I also have Dr. Derek Stout with the Emergency Medicine Department at Sarah Bush Lincoln in Coles County here as well in Mattoon. So thank you all for joining us tonight. Welcome. I'd like to let you know, viewers at home, that we do have an operator standing by, and we have a number that will be popping up at the bottom of your screen, and it is 1-877-727-9348. And if you're a letters person more so than numbers, it's 1-877-PBS-WEIU. Your calls will be answered by an operator standing by in our main office, and she will message me your question via my cell phone, and I will ask it live on air. So if you're afraid that you will be live on air, you won't be. I will be asking the question for you, so don't hesitate to call. The calls will also be anonymous, so don't worry about your name being given. We may ask you what town you're calling from, but that's it. We want to get the information out and educate our viewers and get help to those who need it. We also have a crisis hotline number that we will be putting on screen as well, so if there is somebody who is needing immediate help, the number's right there at the bottom of your screen. We'll be putting it up intermittently throughout the evening as well. But please call and ask your questions tonight. We want to get information out to you. So I'm going to open up the topic by asking, what is opioids? Let's get that information out there. So who would be best to start off answering that question? We're going to be bouncing off of one another here. So let's describe what opioids actually are.
I'm really good at pain relief is mainly what an opiate is. So it's, prescription pain pills like Oxycontin, Vicodin, Percocet, Dilaudid, Norco. Help me out here, Doc. What am I missing?
Yeah, well, there's a lot of narcotics is, let's say that's the umbrella of what we're talking about with just the opioids or opiates. So then you break it down into opioids and opiates, and it's more semantics, more chemistry. Opiates are natural, comes from the opium poppy, and you get codeine and morphine from them. Your opioids are stuff that has either been semi-synthetic or all synthetic, and then that includes your meperidine, your fentanyl, Oxycontin, hydrocodone. So those stimulate a receptor in our body, and it helps with pain, and then it also will give you a euphoria, a little bit of a high sensation. And I think that's where we start having problems with our opioids. They don't just take care of pain, they also give you a sort of a pleasurable response, and some people can't handle that pleasurable response or keep themselves from wanting it more and more.
Okay.
And we should add heroin to that list.
Oh, yes.
Yeah.
Heroin is probably the opiate that most people are familiar with in terms of a drug problem.
Okay, so the difference between that and what he was mentioning are prescription drugs. Heroin is not a prescription, but the rest of the ones that you mentioned are.
Yes.
That's right.
Okay.
And they're all in the same family, which means they all work fairly the same way in different levels of potency and strength. But the difference is that all of those can be prescribed legally, but heroin is not prescribed. It only comes up through regular drug channels, so it's a street drug variant of an opiate, but works the same way.
Okay, so are all of these opioids addictive?
Yes.
All of them are?
Potentially, yes.
Okay, do they have similar side effects, risks involved?
They do. Potency is the main difference. Fentanyl is very potent. You've got heroin, which is diacetyl morphine. That's something that's been manufactured. And like I said, there's no use in medicine for it. That's why it's considered a class 1 and it's 100% illicit. There's no reason anybody should have it because physicians don't use it for anything. So they do all cause very similar things. Constipation, euphoria, respiratory depression, you don't breathe as much. And even if you're not breathing as much, you're not breathing as deep either. It'll cause the typical intoxication. You know, most people will see someone has had too much alcohol. They're slurring their words. They're falling asleep frequently. You see that with any of the narcotics, opioids, or opiates also.
Okay. Right.
And you ask about if they're all addicting. One thing they all have in common is that if you take them for any period of time, you develop tolerance, meaning it takes more and more of the substance to get the same effect. And that's the slippery road to addiction. If you are used to taking a certain amount of any of those substances to get the feeling that you want, eventually you have to take more to get that same feeling.
Okay. And Michelle, you are part of the prevention.
Yes.
So what age do you start talking to people about don't take drugs, these are harmful to your body?
The grant that we received, we start off at 6th grade and can go all the way up to high school. So 6th, 7th, 8th grade is typically where we start. Usually in the middle school, we hope that we're getting them before they're using any type of substances. I'm typically not only just trying to prevent opiates, but specifically like alcohol, tobacco, marijuana, more of those gateway drugs that typically people start off with. And so some of the things that we do for prevention, we do youth prevention education. So that's usually an evidence-based curriculum. So it's been proven that it works. The curriculum that we happen to use, we have 2 different ones that we talk to schools about. One's called Too Good for Drugs, and it's 10 sessions for each grade level. And we usually do multiple grades. We're at least required to do at least 2 grade levels because that will have the most impact long term, where they can get it multiple years. So there's several schools that will go in and will do like 6th and 7th grade. Some schools will do 6th, 7th, and 8th grade, depending on what the school is interested, or we might do like 7th and 8th grade. Another curriculum we use is Project Alert, and that one happens to be like the core year is 7th grade, and it's like 11 sessions that we go into, and then the booster is the 8th grade, and it's 3, and the Too Good for Drug is 10 sessions total. But the thing that we're doing in addition to teaching and doing youth prevention education, we do devote one specific lesson that is on opiates, just because of the increase of problems that we've seen over the last several years, that we are wanting the kids to know ahead of time, you know, really that this is very dangerous and it's highly addictive and you really need to stay away from it.
Okay. All right. Thank you for that. We did get a call in from Champaign, and this is the question. What are we doing about those who have not misused opioids that can no longer get a prescription due to those who have misused the prescriptions?
Yeah, that's a really, pardon me, that's a really tough question, because there are some people that legitimately have pain that can legitimately use an opiate to help them manage their pain, but due to the nature of the drug, the doctors, not speaking to Dr. Stout directly, but doctors know that they shouldn't prescribe them long term in most cases. So for someone that has chronic pain, finding a practical form of pain management for them is getting harder, which is going to be a struggle, I think. What I have seen that has worked for some individuals is finding a good pain management clinic or pain management doctor, a doctor that specifies in pain management. That'll include not only whatever kind of drugs they need, but whatever kind of therapy they might need, physical therapy that they might need, and also work with them to wean down off of an opiate, because we know the strength that it has, that it can take on someone. So helping them kind of wean down their usage can help them with long-term pain.
Okay.
I'd say that's one of the most difficult things for physicians right now. Once it became a big problem, and now everybody's aware of the opioid crisis and narcotics, we talk about morphine equivalent units. So every prescription, pills, liquids, has what we consider a morphine equivalent unit. So it's like if you get 5 milligrams of hydrocodone, that's like getting 5 milligrams of morphine. The recommendation is you generally don't want to give someone more than 50 milliequivalent or morphine equivalent in a day. There are people out there with chronic pain that have been taking 100 to 150 to 200 morphine equivalent units. I'm not saying that they're not having severe pain, but the problem is, and we talked about tolerance, you start out slow and it's not working, so then you increase and you get higher doses. That doesn't necessarily mean that that's a good thing, because those are the people with the chronic pain that are at high risk. You need some pulmonary problems, COPD, sleep apnea. Those are the ones that'll take their medicine at night, and there's a chance they won't wake up, or their breathing rate will slow down, their oxygen level will go down, and they'll just sort of not be right after that. So because now that we know all of this, it's trying to get these patients off of their narcotics. I can't say that we'll be able to get everybody narcotic free, that's irrational to think. But there are a lot of different things to do. Like you said, physical therapy. There are a lot of non-narcotic medications that are out there now that just need to be tried. The other thing is, when people take narcotics for a long time, they get a hyperalgesia, which means even small amounts of pain that would not have affected them before seem huge. So when you're taking pain medicine, that's actually causing you harm, because now even little bits of pain that probably wouldn't have been a big deal seem to have really heightened up, and they feel like they need more and more. So that's not an easy task. I generally don't have to deal with it as an emergency room physician. I have to just be careful what I prescribe, and we don't generally prescribe more than 3 days of a medicine, and you don't get more than 50 morphine equivalent units, because we're concerned about, we want to do the right thing, but we don't want to start doing something that's wrong. It's the primary care physicians that really have a hard task, and I know the patients are frustrated. They get very frustrated. They'll come to us because they want more, because their doctor won't give them more, and it's a long process, and I wish there was an easy way, but physicians everywhere, patients everywhere that's been on chronic pain medicine, it's something we've all got to get together, talk about, and come up with a best plan, because we're not doing it to be mean. We're doing it because we're concerned about our patients.
Right, yeah, that sounds sensible. Let's talk about why there is a crisis now. Let's explain that to people, because we know that there's been drug problems forever, and we've heard about opioids, we've heard about meth, and all these different things. What caused this term crisis to come about?
I think part of it was like overuse of prescription drug, or over prescribing of opiates. And there's an economic problem that we have when we talk about opiates, because when someone begins to take more than they're prescribed, or take it longer than prescribed, this tolerance is built up, like we've talked about. And eventually a doctor is going to say, all right, I can't give you any more. So they might try and find another route to get the medication that they want. And they might then begin to turn towards street variants of pills to get the drug that they want. But they might also turn to heroin to get the drug that they want. And heroin is cheaper, stronger, and more readily available than prescription pills are. So it's an economical reason that people change to heroin. So, imagine you have a large population. We've been kind of we as a society have been okay with them having, these higher level of opiate prescriptions in their house. And now we've restricted that. So then they turn to the street variant, heroin, which is stronger, cheaper, and more readily available. Not realizing that these opiates have a really strong chemical dependence that's caused here. People aren't just addicted to this, they're chemically dependent, which means they don't feel good unless the drug is present.
Okay.
Meth doesn't do that. Marijuana doesn't really do that. Cocaine doesn't really do that. Not in the same kind of severity that opiates do. So it's a very unique drug in that sense of it causes a heavy chemical dependency on someone.
So then they want it more and more and more.
Well, not just that they want it more and more and more, it's just that they want it so they don't feel sick.
Okay.
Yeah. So if the drug's not present, they feel sick, and then it's hard to get up and do their jobs and take care of their kids and go to work, all the things that people do. So when the drug's not present, they're not able to do those things as well, which means it's harder for them to keep a job. Right. It's harder for them to take care of their kids or take care of their parents or, be a good neighbor kind of thing. So, so it's an economical problem and a chemical problem all rolled into one. And then treatment is challenging. I think, Judy, you can talk about treatment is challenging for a lot of folks.
The other thing I would add in answer to your question about crisis, eventually most people who use heroin inject it. And when you're injecting a street drug, you have no idea of what's actually in that drug. So you buy some heroin, you have no idea what the actual ingredients are. And if you're injecting it, it's a very immediate, it's in your bloodstream pretty well immediately. So I think part of the crisis is the overdose, the frequency with which people overdose.
Okay.
Certainly people ruin their lives with drinking and with marijuana and with cocaine and with methamphetamines, but typically they don't inject, except for meth, those other substances. The overdose potential, I think, is part of what's made this a crisis, is because people are dying, and they're dying quickly, not after many years of use.
So let's talk about that. You said people don't normally start out by injecting. What gets them to that point where they decide, yeah, this is something that I'm going to do?
I think what Joe said, we've talked with our clients. Last time I talked with them, out of 20 people who were in treatment for, heroin addiction, 19 of them started with prescription medication. They had torn rotator cuffs or car wrecks or, they had to have surgery, and they got a month's supply of opiates. And by the end of the month, they were abusing them. So the story that Joe told, they were abusing them. They were running out before the script was due to come in.
Right.
They were stealing them from their neighbors and their relatives. Then they were buying them on the streets. When they get to heroin, that's just the best way to use heroin.
Okay. So if someone is in this situation, and I'm thinking from a viewer's standpoint, a family member, a friend has had a surgery or had a car accident or something and was given this prescription, and then they start to notice they are taking them a little bit more frequently than they need, or what does that person do or say at that point in time to that person who they think is going down this road? What can they do or say?
Well, first of all, I don't think that, I think there's been some real changes in how much is being prescribed, and you could maybe speak to that better, but I believe the days of a 30-day supply, because you had your wisdom tooth out, is, I think we're getting smarter about that. In every question about how do you deal with a loved one with a drug problem, you tell them the truth lovingly. Shaming people and screaming at them and calling them names isn't helpful in
say
changing
what you
anybody's
mean, but
behavior.
don't be mean when you say it.
Right. And, so I think you have to say it. I think you have to say, why are you still taking those? It's been 3 weeks. Why are you, I thought you should be better by now. I think you have to speak up and say what you're seeing. If they've got a complication of their surgery or of their illness, whatever it is, they need to be back to the doctor getting that complication treated.
Okay.
So I think, saying what you're seeing.
And then what normally would happen after that, if they don't get the response from their loved one, then I think this is the spiral that people don't know what to do. Right. And I don't know, I want to be able to give some information out there on some resources or places to lead these folks on where to turn and maybe how to seek some help earlier on instead of ignoring it or maybe thinking, okay, this will go away or something like that. What are some answers that we can provide our viewers who are tuning in right now?
Well, I think anyone that is starting a prescription of opiates or has started or has one ongoing needs to know that they might need to be weaned off of them. That just cutting them off cold turkey might not be beneficial. That in some cases, some people might need a gradual lowered use of an opiate. And that during that gradual weaning off of the drug, they might have pain. We kind of have this mentality of, oh, I have pain, I shouldn't have pain. And you might need to have a little pain. A little pain might be okay for you. A lot of pain, sure, that's bad. But a little pain, we might need to learn to manage that. And I think sometimes in the opiate crisis, we forget that opiates are really great at managing pain. That's why they're out there. That's why they work. That's why doctors prescribe them. So I think we need to tell somebody look, you might be taking more than you really should. Let's slowly work on lowering the amount that you use, slowly, gently. And at the same time, talk about access to behavioral health or seeing a counselor. Maybe the trauma of the pain that they're dealing with has brought up other things that the opiates help take away.
Okay.
So I think mental health counseling is a critical piece of recovery and prevention.
All right, that's good information for our viewers. Thank you for that.
I think that from the physician side, like I said, I don't prescribe more than 3 days worth of pain medicine. And that's usually because, I think we're talking about there's lots of different types of pain. You fell, you broke your wrist, that's something that'll stop. Knee pain that's been chronic for a while, you need to start thinking less narcotics, more alternatives, because now we're talking chronic. Acute pain for a little bit's one thing. Now when I give out narcotics, I let every patient know for sure this is a narcotic. You need to be careful. This is habit forming. The other thing that's come out in the last couple of years are prescription monitoring programs. The state
I'm
does.
glad you got to that because that was the question I was going to ask you, so please do speak on that.
So the state, multiple states have prescription monitoring programs that physicians and pharmacists have access to. So if someone comes in and they've got, pain, before I prescribe a narcotic, I'm checking the prescription monitoring program. So I click a button, I get onto it, and I can see how many prescriptions, now these are just controlled prescriptions, how many controlled prescriptions, which means it has to be habit forming or addictive. And then I can see how many they've had. If they just had hydrocodone 10 days ago for 30 of them, I don't necessarily know if they need more pain medicine. Sometimes the patient won't be up front, which is a red flag. Sometimes they will be up front and just flat out say, I need more. That's something that, a discussion has to be made. You know, like I said, I'm in the ER. I think a lot of this also has to the responsibility of the primary care physician. It should be one physician prescribing the narcotics, then that's it. You get someone that goes to multiple emergency departments, that's concerning.
Yes. Because
it's different doctors. I don't know you. Well, now with the prescription monitoring program, that helps diminish that, I think, which is good.
Yeah, that is good. That answered the question that we just received. And then there was also a follow-up question to that. Programs to help those who are admitted for overdose or addiction, such as Narcotics Anonymous or Alcoholics Anonymous. Are there programs specifically for those admitted for overdosing?
So Narcotics Anonymous would be a great route for someone that has experienced an overdose, because they'll get a chance to talk to other people that might have experienced something similar. I mean, any drug treatment facility, whether it's folks like Seed or anywhere else, are going to be good resources for folks. So, you know, an overdose is simply, an opiate overdose is simply using more potent or more drug than the person can handle at that moment. And anyone that uses opiates is susceptible to an overdose. So it's not a special case. It doesn't tell us something more about that individual if they are experiencing an overdose.
Okay.
So any other form of drug treatment or drug counseling would be effective for them.
All right.
The other thing I'll just add is that I think it's important for people to realize that rarely does someone just use opiates. I'm not sure if I know anybody who just uses opiates.
Right.
The people that we see in treatment that have a problem with opiates also drink and also used benzodiazepines or, you know, nerve pills. They smoke marijuana. They've dabbled in meth. They've used some cocaine. The heroin may be what got their attention. That may be what caused the overdose or, you know, caused the crisis that made them seek treatment. But most of those folks already had a drug problem. Okay. Or an alcohol problem. So yes, treatment of any kind, Alcoholics Anonymous, Narcotics Anonymous, those are all good options.
Okay.
The other thing, the Substance Abuse Mental Health Services Administration, if you type in treatment locator in a Google search, it'll easily come up with their website, and various treatment programs across the United States are listed on there that have been licensed to do substance use treatment, and it includes mental health facilities as well. And so along with the opioid hotline, that is another resource and treatment is not just only for our clients, it's for family members. So if there's a family member that's struggling with wanting to know what maybe they can do, they can still seek out a treatment facility to try and get some help and to talk to someone.
Okay, that's good information to get out, because sometimes I think maybe people would think, well, they're not going to answer my questions. That's for the person who's having the difficulty right here. Okay, good. Thank you for that. Let's talk about overdose and what exactly happened, some of the symptoms, I know you have something that you want to talk about that has to do with reversing it.
Yeah.
So let's talk about maybe what you need to look for if you're around somebody, and kind of walk our way through the reversal. So who would like to start?
I would.
Okay.
So I've trained a lot of people on administering Narcan and recognizing an overdose. And mainly what we train people in an overdose is simply, someone's tolerance for opiates that day is here, and the drug just went beyond it. It's not a magical set number for everyone. It fluctuates all the time. But for folks that use opiates daily, their tolerance is usually really high. And when an overdose happens, it either means that the drug went beyond their tolerance or their tolerance lowered. And typically we see that when it's mixed with any other type of drug or alcohol, that lowers the tolerance. Or if they've gone for even as little as 3 days without using, that lowers the tolerance as well. Or if their tolerance is here and the drug is mixed with something else that we don't know about, which heroin often is, most of the time is mixed with something else, Fentanyl being a really good example. So their tolerance is here, and the fentanyl has pushed the opiate way beyond their tolerance then. So anytime that those two lines cross, then an overdose is triggered on someone. What it typically looks like, it looks like the person falls asleep or passes out. It's from a lack of air that has happened. So they might be breathing a little bit, but they're not breathing enough or not breathing deep enough to remain conscious. So most people just fall over, and it looks like they're sleeping or passed out. Some folks will see like blue lips or like blue fingers or blue face. That's an indication that they've gone for a little while without air. In the US, most people don't die from an overdose if two things happen. Somebody sees it and somebody does something about it, which is calling 911. So at a minimum, if someone sees someone unconscious and calls 911, they have like a 70-75% chance of surviving. That's pretty good.
Yeah.
So, you know, one of the things that I think is really important that people know, like, if I just call 911, this person could be saved. But we have to understand that if there are illegal drugs in the mix here, there might be some legitimate hesitations why someone might not want to call 911.
But there is something that's come out about that, right?
Yeah.
And I believe both of you mentioned it, and I think maybe you mentioned it the other day. It's called the Good Samaritan Law.
Yeah, so the Good Samaritan Law offers protections for the person who is unconscious, and it offers protections for the person who makes the phone call. It also offers protections if there are small amounts of illegal drugs in the area. I can't remember the exact quantities off the top of my head, but small amounts of, if there's a small amount of heroin in the area, you're not going to get someone's not going to get prosecuted and arrested right then for it. So it's really similar to like alcohol amnesty laws that a lot of college campuses have for underage drinking. So the idea is the same. If your friend is underage and they pass out, or there are other underage people nearby and they're drinking, we want you to still call 911 for them.
Yeah.
Same rules apply now to heroin. That if someone is using heroin, which we all know is illegal, we want you to still call 911 if somebody passes out or it doesn't seem like someone's breathing.
Help save their life.
Yeah. And that gets EMTs to the house as fast as possible, and EMTs carry Narcan.
Yeah.
Folks can also do rescue breathing for them, which just puts more air into their lungs. That's a very beneficial technique that can be used to sustain their life until the EMTs are able to show up. Okay. So,
and then they get to you in the emergency department.
And they get to me. Yeah.
So then what?
So generally by the time I get a person that's overdosed on opiates or opioids, they've already been given the Narcan, the reversal agent. And I can tell you that is the only thing that has kept them alive. Otherwise, if we didn't have any of that, a paramedic would have to intubate, put a tube in, and breathe for them. That's really very rarely ever needed to be done anymore, unless, like you said, someone's had heroin generally that's laced with something extremely potent, like carfentanil, which is anesthesia for large animals, and it's not even supposed to be used for humans. They get that. Sometimes they have used all of their, the EMTs, paramedics have used all of the Narcan they have. So then when they come to us, we have to give them more Narcan. Well, by the time we're thinking about giving that much, we're already having to put a tube in to help them breathe. Because then the concern is maybe of something other than opioids. So once they get to me, generally they're already awake enough. We don't want to give a reversal agent so much that we put them in overt withdrawal, because they'll be throwing up, they'll feel horrible, they're not going to want to stay where they're at, and that's not safe for them. So we generally just try to give them enough Narcan so that they're breathing normal. They may still be sleepy, but as long as they're breathing normal and we can check their oxygen level and their carbon dioxide, the gas that we use to breathe out, then we will allow them to just be there, because we know they're safe and they're not going to get hostile and they're not going to want to leave. After you give the Narcan, you generally want to try to observe someone for 2 to 3 hours. And the reason for that is some of the medicines that people are taking are going to last longer than the Narcan is. So they take something extremely long-acting like methadone, and they took a lot of it. Methadone can last up to 24 hours. So you can give them Narcan, they look great, and then in a couple hours after the Narcan wears off, then they can start to sink down, respiratory depression, start turning blue again. So we need to, those are the ones we generally need to admit, and we have to keep them on a Narcan drip. I mean, those are very serious. After they're out of the woods, we always talk to them about, one, why did they do it? You know, there's accidental, and there's, I don't want to live this way anymore. I tried to kill myself. The people that are trying to kill themselves, we can't let go home because they're going to try it and they're going to succeed at some point. So those are the ones that are admitted, even if they don't want to be. And those are the ones that need to see a psychiatrist, and there's a whole lot of things that goes on then in the inpatient side. And when they're discharged, there's generally plans there also. The ones that accidentally did it, they got a bad batch, they got it a little too strong, they don't want to stay. We can't keep them against their will. And by that time, hopefully there's friends or family that are there. Mm-hmm. They understand what's going on. I explained to them that the Narcan, you know, is a reversal agent. And at that point, I've started to prescribe Narcan for them. I write a prescription. I hope that they get it filled, because that's where someone does something in front of you, mm-hmm. and they pass out, and you know where their Narcan is. That's something that easily a layperson or somebody that's not medical trained can give, and it's usually through the nose with a little atomizer, and that will help bring them back. It'll help, at least their breathing will get better. That in no way means you don't call 911. You still call 911, but at least it's been given, and then the rest of the treatment can happen. Okay. And I'd like to say that, you know, in the ER we're never upset or anything like that. We try to make sure we don't treat somebody that's abusing drugs doesn't want to abuse drugs. It's just happened. They've got it's got a hold of them, and this mm-hmm. was an accident. And you know, I don't want somebody to not call 911 or come to the ER mm-hmm. because they feel like, oh, they're just going to treat me like a druggie. Right. We'll do our best to try not to treat you like a druggie. We're not going to give you any pain medicine or anything like that. But you know, that the important thing is that someone's passed out. The whole reason for these Good Samaritan laws is before they'd shove you in a car, drive you out somewhere, throw you out of the car, and then call 911 and say they found somebody on the side of the road to try to prevent the person calling from getting in trouble. That's the whole point of the Good Samaritan law. Yeah. It's your friend, your family member, whoever is passed out and needs help. There's a chance they could die if treatment isn't given. And get them help. Just call 911.
Well, and Narcan can also be purchased without a prescription at just about any pharmacy. Just check your local pharmacy. You should be able to buy Narcan. Anyone can buy it. You don't need a prescription to get it now. I appreciate that you do give out the prescriptions, because a lot of folks need to be aware of it. Mm-hmm. Most insurances, Medicare, Medicaid, will help pay for it, so it's not too expensive. So if someone has a family member or a friend that they're worried about that's nearby them, you can't use Narcan on yourself. Someone has to administer it. You know, someone has to see someone that is passed out in order to give them Narcan. So I've talked to several parents that are like, hey, my kid's getting out of rehab. They're moving in with me. What do I do? I'll tell them, check your local pharmacy. You might get Narcan. You know, and that'll at least help you just in case something happens.
Okay, thank you.
I would like to say that Narcan's just not for people that use heroin. Right. It's for people that take the large quantities of pain medicine that are prescribed by their doctor. Those are the ones that may need it even more because you just don't know. So I mean, this isn't just somebody that uses heroin. This is somebody that is on high dose narcotics that are on it for a reason. You know, you just never know. Okay.
So can someone harm somebody by giving it to them if they don't know if they're just asleep? Go ahead and give it, just to be on the safe side?
Yeah, so Narcan is perfectly safe on anyone, whether opiates are present or not. Right. So even if someone has had a heart attack or stroke or a seizure, you can still call 911. We still want you to call 911, obviously, but if you have Narcan, it's safe to give them. It's not going to make anything worse.
Okay.
Yeah, you can try to arouse them, see if they'll wake up. The other thing to think about is When people overdose on narcotics, a lot of times it's just not narcotics. It's benzodiazepines, sleeping pills, barbiturates. So the Narcan will reverse the narcotics.
Alcohol.
And alcohol, right. The narcotics will, or the Narcan will reverse the narcotics. It won't reverse anything else.
Okay.
So, I mean, that's what we do. They come into the emergency department, we don't know what they took.
Yeah.
The first thing we're doing is we're putting them on oxygen, we're checking their blood sugar, and we're giving them Narcan. And if the Narcan doesn't work, then we need to start thinking of other avenues of what else could possibly go on. So giving Narcan, I don't think there are many untoward effects for Narcan at all. I would recommend it.
All right.
The other thing that sometimes I've heard people say that they'll wonder about with the Narcan, aren't you enabling them to continue using? But you know, one of the things whenever Joe came and talked to us, that's what he said. He goes, you know, it's not like that. They're going to be mad because you're destroying their high, basically. And so whenever they come off of it, they're going to feel bad because they're going to be in withdrawal and they're going to be upset about that. So you basically are saving their life. And wouldn't you, I mean, we hope that they get into treatment and they're going to get the help that they need, but definitely to save their life so that they can be around to try and do that is what, you know, we really want to try and do.
Absolutely.
The whole enabling thing. Yeah, the Narcan is just to save your friend's life. It's better to be alive than be dead. The other thing that I know a lot of people have had problems with are syringe exchanges. You know, you think that if you give someone a syringe, you're saying, go ahead and shoot up. Well, that's not what we're saying. The problem with using dirty syringes is you've got the drugs that are a problem. Now you've got infections that are very atypical in someone that uses IV drugs. You've got hepatitis B, hepatitis C, you've got hepatitis A, you've got HIV. Everything that seemed to be we were doing a good job on is now starting to resurge again because of the increase in IV drug abuse with heroin.
Yeah.
So, you know, the new IV or new syringes at syringe exchanges, using the cotton that they use for filters. I mean, there's a lot of different things that happen, and if they're not new and they're going to do it anyways, you try to keep the, you know, my job is to keep people safe. So even though it seems very strange and it seems like maybe I am enabling, I'm not. I'm trying to keep, if they're going to do it, they're going to do it. Let's have them do it as safe as possible, and then hopefully with treatment, they'll decide they don't want to do it anymore, and they won't have to do it. But at least this way they're not spreading HIV, hepatitis C, hepatitis B to anybody else.
Well, and I think that's a really good message to send someone that is using drugs to say, like, okay, if you're going to use drugs, let's at least keep you safe and alive. That's a very different message than the old messages of drug of, you know, just say no. You know, we're still saying, yeah, we don't want you to use drugs, but if you do, let's use them as safely as possible. And let's implement life-saving techniques and practices to keep you alive until you're ready to stop. Because most people do eventually find a way to stop. Whether it's drug treatment works, they have a significant life change, like they have a baby, they get married, they move, they get a new job. All of those can be enough to trigger someone to say, okay, I'm really ready to stop using now. In the same way that something happens for someone and eventually they find a way to stop smoking.
Yeah.
Same kind of mentality of like, all right, this is enough reason for me to stop smoking, I'm ready to quit.
And something that I talked to all of you about preparing for this show is the stigma that is attached to the folks who are using and how they feel about themselves and how they're treated by others, and finding that value within yourself. So let's talk about that a little bit from the prevention treatment and talk about that stigma that's involved.
Well, we know that the stigma of drug and alcohol addiction is part of what keeps people from seeking help. It's part of what makes people want to believe that's not their problem. You know, they'd rather believe they have some other kind of problem. And you know, the one thing we can say about addicts and alcoholics is in the early to middle stage of their disease, the drugs and the alcohol to them are the solution. They're not the problem. To them, you know, what they're taking is what makes them feel human, makes them feel good, makes the sickness stay away. So, you know, it takes a while for people to understand that actually the drugs and the alcohol are what's creating the misery. And if they have access to treatment, and if somebody sees that they get access to treatment, we know it's a treatable illness. There are a lot of illnesses that people's behavior has a part of. And there are a lot of illnesses that people get treated for and they're not compliant with the treatment. And this is just like those.
Okay.
You know, people need to get professional treatment. They need to get treatment for addiction. It's a specialty. And then people need to understand that they didn't do this because they intended to hurt people. You know, this wasn't a, you know, I woke up when I was 10 and decided to grow up and be a drug addict. That's not anybody's intention.
Right.
When I talk to the kids in the schools, that's one of the things that I try to explain to them is, you know, if you talk to anyone, and usually we're starting, you know, more with like where we're talking about alcohol and tobacco, but I'll say, does anyone know anyone that smokes? And they'll raise their hands. Ask them if they thought they were going to be addicted to nicotine or if they were going to be addicted to smoking cigarettes. They would say no. That's usually not what they think. Yeah, I want to smoke a cigarette or I want to drink alcohol so I can become addicted to it. You don't think those ways. The brain changes along the way, and that's because the brain chemistry, how that goes, it changes, and so then they don't have a choice. They may have made that initial choice to use, but whenever it gets to the point where they have a substance use disorder, that choice has been taken away because the brain has already changed for them.
And it can change differently in different people. I mean, some can tolerate more, some can't. So it just depends. There's no set like. And
history, if there's a history of substance use in the family, that can cause a greater risk. And you know, the other thing I talk to the kids about is the younger, if you start using or trying or experimenting when you're younger, their brain is not done growing and developing until around their mid-20s. And so they have a greater chance of becoming addicted because the brain is still under construction. And so you don't want to add any substances to that could cause you to become more easily addicted.
Okay. All right. We have something here that I think you gave me called Don't Be the Dealer. It's a take back day. Let's talk about that. So if you do have drugs in your house and you're thinking, I don't know what to do with these, what do you do?
Okay, so the Drug Enforcement Administration, this is something that they usually host at the end of October and at the end of April every year, and it's called Prescription Take-Back Day or Drug Take-Back Day. And so October 27th, so this Saturday is going to be Drug Take-Back Day. You can get on the DEA's website or just type in a Google search that says Prescription Take-Back Day or Drug Take-Back Day, and you'll be able to pull up a link where you can then find out where are the take-back locations that are in your area. So this Saturday, there's a lot of different places that are offering some of those. So I know you cover a wide range of counties,
we do.
So that would be the best way to find out. But to just look, it's going to be from 10 a.m. until 2 p.m. And any prescription drugs that someone has in their home that they can easily, that they don't use anymore, whether it's pain medicine types of things or other things. If there are animals that you've had that were on some type of medication, you don't need those anymore. Get them out of the home, because that's one of the ways that if people find drugs and if they're wanting to experiment with younger kids, if they're or middle school, high school age, if they start experimenting, they might find prescription drugs that are in the home. And so we want to eliminate that and get that out of there.
And it's better to take them back like this than flush them, because then it gets in the water and who knows where.
Right.
So, okay. All right. I did a little bit of math because we do cover 21 counties in Illinois. We go into Vigo County, Indiana as well in our broadcast viewing area, WEIU. And so online, some of the resources you gave me, back in 2017, in the 21 counties that we broadcast to, there was reported 186 overdose deaths. And 128 of those were from opioids. And that's just in 2017 what was reported. And we're guessing the numbers higher from some of the conversations that we've had. So, you know, I just wanted to see the math and see what it was like just in our 21 counties. And that's not counting the rest of the state. Or, you know, I read, I think it was in 2016, there was something over 40,000 overdose deaths in the nation in 2016, and it's been on a rise since then. So You know, I'm glad we're doing this program tonight. I think we've got a lot of information out to our viewers. I think we've talked about a lot of different topics that are helpful. We have about 5 minutes left. I want to have each of you maybe say some closing remarks. If there's something we haven't touched on, this is the opportunity to get the information out, and then we'll wrap up the show. So we've got a couple of minutes left. Who would like to start? Just jump right in there.
I'll just end by saying treatment works. And so if there's someone watching that's concerned about their own or somebody else's drug or alcohol use, you know, I would urge them to call the 800 number that's on the screen and see about getting somebody into treatment. As you said, Joe, earlier, it's not easy. Treatment isn't easy, but there is hope. And I think sometimes folks have kind of lost hope that their life can be any better. And I want them to know it can.
And for the loved ones, don't give up hope on who you love.
That's right. And as Michelle said, loved ones can get help also.
Mm-hmm. Okay, yeah. Thank you.
Thing that I would mention, we have two media campaigns that are being done. The Substance Use Prevention and Recovery Division of the Illinois Department of Human Services. They have the opioid helpline, the Ending Opioid Misuse campaign. That's one of the things we provide and help to promote and get posters and different things like that out in our communities. And then another one is called Guard and Discard, and that's the prescription drug one that we're trying to get that out. So not only with drug take back, but with some of these media campaigns where we're posting, putting up posters and postcards and different things like that, trying to make people more aware of it. So they're seeing it more often, they're thinking, yeah, I need to get those prescription drugs out of the home.
Okay, thank you.
I would like to say that for the drug using population out there, you matter. You may not feel like you matter, but you matter. And there are programs. I mean, I was really happy to hear Doctor here tell us, like, you know, we just want to keep you safe. And I think so often we label people that use drugs with terrible names and tell them they have to get clean, and all these ways that we just add negativity to their life. And I think the message needs to be like, there are people that care about you. There are people that care about you while you're still using. And we want to keep you safe.
Absolutely. Thank you.
From an ER standpoint, I appreciate if whoever comes in that is overdosed, you just tell me the truth. Don't lie about it. Don't try to hide it. I don't ever call the cops. I'm a mandated reporter, and that's not something that we're mandated to report. I'm not a police officer. I'm just there to help you. So after an overdose or anything, you just need to be honest with me, any of my partners, your physician, because it's not a legal law thing. We're not going to get you in trouble. We just want to help you. The other thing is we've given great resources. If at any point you don't remember anything or you don't know where to start, you can always come to the ER. We might not admit you or treat you or anything, but at least we can give you what you need to know where to go, phone numbers. There are times I've even been able to get somebody into a treatment program if there was a spot available somewhere. You know, and just the best thing to do is the prevention. Try not to start, but if you do start, try to be as safe as possible, and there's everybody out there to help you.
Thank you so much. Great panel of guests tonight. Thank you all for joining us. Sure. Thank you for all the information that you have provided our viewers tonight. Very important topic. Thank you. And thank you for watching this special edition of Being Well. We hope that this has been informative. Please listen to the information that has been given by this special panel of guests. Our show tonight will also be put up on YouTube, so you can link it, you can share it, post it, share it with your loved ones, and make sure that this information gets out. I'm Keanne Armstrong, your host for Being Well. Thank you for watching.
Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System.
At Carl, we dedicate ourselves to helping you be great. And we have the expertise, and inspiration to help you stay that way. Meeting the ever-changing healthcare needs of our communities, Paris Community Hospital Family Medical Center is now Horizon Health, with the same ownership, management, providers, and employees. Horizon Health provides patient care and promotes wellness to the communities of East Central Illinois.
At HS St. Anthony's Memorial Hospital, we are at work transforming heart care, rebuilding knees and hips, delivering new generations, and focused on providing health care to you. We are HSHS St. Anthony's Memorial Hospital.